Hey, what is up? And welcome to world number 8 in Power Up Endo's 90-day Super GP training program. In this world, we're going to cover antibiotics, post-operative complications, as well as post-operative pain. Let's get right into it. So level 1 of World 8 is all about antibiotics. And before we get into the nitty-gritty, I want to preface this entire level by letting you know that I'm not going to get into the deep weeds of the mechanisms of endodontic disease or the mechanisms of antibiotics themselves. I'm going to give you a zoomed out view and only the most clinically relevant information, as I've done in this entire training program, for the average clinician to have the necessary information to apply for their patients in their general practice. Okay, so don't get too scared. We're only going to be getting into what you absolutely need to know. So first and foremost, as you already know, endodontic disease starts with an inflamed pulp that eventually will lead to an infected pulp after it's become necrotic. Generally speaking, immune cells release inflammatory mediators that are ultimately going to recruit and induce osteoclastic activity in the periapical areas within the jawbone. So that's a very zoomed out view of what's happening in terms of the mechanism. And then it's a feedback loop where there's going to be recruitment of more and more immune cells to defend the patient, and that just causes an increase in the speed and the amount of bone loss that occurs. And bacteria and bacterial byproducts in the periapical region cause nerve tissues to release neuropeptides and cytokines, which induce inflammation, recruit more immune cells, and ultimately create this feedback loop where osteoclasts resorb the bone, and just the increase in inflammation causes pain and causes the potential for an infection. And antibiotics themselves are not a silver bullet, as you know. Antibiotics are not going to penetrate into the pulp space and disinfect the inside of the tooth. They're only an adjunct to be used in combination with some sort of dental treatment. That dental treatment is either endodontic treatment or removal of the tooth, which is obviously going to remove the source of infection, which is the pulp space itself when we're dealing with endodontic infections. And classically, antibiotics are not needed in the majority of situations. And I'm going to go over that with you, but unless you have systemic signs of infection, generally speaking, antibiotics are not needed. But again, I'm going to go over the indications with you. Debridement of the pulp tissue, the infected tissue, along with the bacteria that's inside of the tooth, is far more effective than antibiotics alone. You might want to do a combination of the two in certain situations, and like I mentioned, I'll go over that with you, but debridement of that tissue has to happen. And that happens either through root canal treatment, or if the soft tissue is infected, through an incision and drainage procedure. Some sort of dental treatment is needed for an endodontic infection. Antibiotics alone generally are not going to cut it. The situation where you have a patient who has an infection and telling them that, we're going to get you started on antibiotics and appoint you after the antibiotics have had a chance to work, that's not really adequate, and that's not really what is recommended in terms of the best practice for your patient. You have to be proficient so that you can manage these patients in a timely manner. Just giving a script of antibiotics and appointing this patient and saying good luck with that, it's not really enough to do a proper service for your patients. It's generally understood that dentists are not very appropriate oftentimes with their prescribing habits when it relates to antibiotics. We're one of the worst offenders in terms of inappropriate usage of antibiotics. And that's mostly having to do, I think, with trying to please a patient who thinks they need an antibiotic. All right, but there have been studies such as the one referenced here that have shown that greater than 50% of dentists actually inappropriately prescribe antibiotics, which is not good, clearly. Also, when you're dealing with a vital pulp, it's very important to understand that a good rule of thumb is that antibiotics are not really going to help. Granted, analgesics may help, such as ibuprofen or Tylenol or even a narcotic, but antibiotics in an inflamed pulp that is still vital are not indicated, and they don't really do anything. You have to remember that endodontic pain comes in waves, and there's times where it's much worse, and there's times where it gets better, and it kind of goes in these cyclical waves. And you might be seeing a patient in your practice when they're at the top of that wave, and you prescribe them an antibiotic, their pain level goes down. More often than not, that pain would have gone down regardless of the antibiotics that you prescribed them. But they might perceive the antibiotics as being the reason why they got better, but usually it's simply time and the cyclical nature of endodontic pain. Now, when a pulp is necrotic, okay, that's when we're dealing with infection. And that might be when antibiotics actually help. But again, only in certain situations, which I'm going to go over with you. When you're dealing with a primary endodontic infection, primary endodontic infection is a tooth that's never received endodontic treatment, and secondary is a tooth that's been previously treated. But with primary endodontic infections, we are initially starting with aerobic bacteria as well as facultative aerobes, and then as time progresses, the environment is more suitable and is occupied by a greater number of anaerobic bacteria. That's just a factoid that you probably should understand. And generally speaking, antibiotics are only indicated for these specific situations. All right. So first would be a patient who has an acute apical abscess. And remember, acute apical abscess is generally when your patient has some form of swelling. But an acute apical abscess in an immunocompromised patient, number one. Number two, acute apical abscess in an immunocompetent patient when you cannot perform treatment that same day, which I would generally recommend you don't put off the treatment, so that wouldn't be necessarily a good indication, but technically that is one of the indications for prescribing antibiotics in an endodontic infection. And then thirdly would be, again, acute apical abscess when there's systemic signs of infection, right? So fever, malaise, lymphadenopathy, but obvious big-time problems going on. But these are all relating to a periapical diagnosis of acute apical abscess, which is the vast minority of the clinical situations that you will encounter, me included as an endodontist. As a broad rule of thumb, the literature consensus is that antibiotics are not indicated in a healthy patient, even with a small localized swelling. Debridement of the source of infection in the form of endodontic treatment or dental extraction is what is recommended for these patients without utilizing and prescribing antibiotics. That is the academic viewpoint. Is that always the case for me, that I won't prescribe antibiotics outside of these scenarios? Not always, okay? But you have to understand that generally speaking, we tend to overprescribe antibiotics, and I would encourage you to be very firm with when you do and don't prescribe your antibiotics. And like I mentioned, antibiotics are not indicated for symptomatic irreversible pulpitis, which is clearly a vital pulp status, or symptomatic apical periodontitis, which can be vital or necrotic, but does not involve swelling. So swelling is really the key to whether or not you're going to decide to prescribe antibiotics. Now, I like this image here because we're all put into these situations in our practice where a patient wants to strangle you because you are insisting that antibiotics are not indicated and a good idea for their clinical scenario. So I sympathize with you because I understand those patients who insist on getting an antibiotic because they think it's going to help their situation. And I'm not telling you to kick them out of your practice. I'm encouraging you to educate them. I'm put in these awkward situations as well. So I hear you. I sympathize with you and for you. I know it's tough in private practice, but just remember, in terms of what the literature recommends, recommends and what academia recommends, what the textbook recommends, there's only a narrow window of when antibiotics are actually indicated. And I encourage you to stick to your guns as much as you can. And in terms of what to prescribe your patients who have endodontic infections, this is what I would generally recommend, and you probably already know this. Amoxicillin 500 milligrams is generally the antibiotic of choice unless allergy is present, in which case clindamycin is utilized. All right, now, if a patient has a severe infection or a persistent infection, I will oftentimes prescribe Augmentin, which, as you know, is amoxicillin with clavulanic acid booster, and we prescribe that just like we prescribe amoxicillin in terms of the quantity and the frequency. Also, I like to use booster doses for a patient who has a severe situation in these acute apical abscess scenarios. All right, so I always do an initial double dose for these patients. And as recently as May of 2021, it's starting to come to light, and it's starting to be presented that as opposed to clindamycin for the substitute when an allergy to penicillin or amoxicillin is the case. Okay, so as opposed to clindamycin, we're starting to see the academies recommend utilizing cephalexin or Keflex as opposed to clindamycin for allergies to penicillin or amoxicillin. You're going to see that more and more in terms of publications and newsletters that you might be receiving, the phasing out of clindamycin and the replacement of clindamycin with Keflex. And there you have it. That is all you need to know for using and utilizing antibiotics in your general practice for endodontic scenarios. That's going to cover you. Like I said, I don't want to get into the weeds because this is a relatively large training program with a lot of information. I'm not going to bombard you with minutia. So I will see you in the next lesson.